This week on the BackTable Podcast.
I think case selection is really important, especially early on with a new platform. So you don't want to pick patients like your typical patient probably, but you want to pick patients that maybe have a virgin abdomen or less surgery where you're not expecting a lot of transumbilical adhesions. But I've gotten in those cases, and that was something that I really thought about when I started, because you can only fit one robot in a room. So when the SP was in the room, I couldn't convert to an XI case if I had to. So I had to think, if I have to convert, I'm converting to either laparoscopy or laparotomy. So if I had a lot of adhesions, then I had to either decide, am I going to do this with single-site laparoscopy or multi-port laparoscopy? And so I had to have some at least baseline skill set to be able to do a single-site laparoscopic adhesiolysis. And I've had a few cases like that where I've taken down some momentum and things like that. So it does take that skill set. You know, it's just like even with robotic surgery, you have to be a good laparoscopic surgeon to get in and dock the robot, right? So you still have to have those skill set to be able to take down those adhesions.
Hello, everyone, and welcome to the BackTable OBGYN Podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com.
Hey, this is another episode of BackTable OBGYN with my co-host, Mark Hoffman. Hey, Mark, how are you doing?
Amy, good to see you. Amy Park, our star host today, and it's always fun to be with you.
And speaking of stars, we have a star in the field of urogynecology as well as minimally invasive gynecologic surgery, Dr. Johnny Yee. Dr. Yee is a urogynecologist and associate professor of OBGYN at Mayo Clinic, Arizona. He's actively involved in the education of both surgical fellows and med students. As a clerkship director of OBGYN, he's navigated the surgical education in OBGYN, emphasizing the need to utilize available surgical video resources online to acclimate to pelvic anatomy and minimally invasive surgery. He's also mentored his fellows in creating many surgical videos geared towards educational teaching with a focus on surgical anatomy and technical aspects of surgical procedures. His clinical interests are in the surgical management of pelvic floor disorders and has particular interest in innovation in robotic surgery. So welcome. Thanks for coming, Johnny.
Thanks for having me.
So, it's super cool, first of all, that you are bridging urogynecology and minimally invasive gynecologic surgery. I know we brought you here to talk about single-port robotic sacral colpopexy, but can you just say a couple words of your perspective on that?
Yeah, I think, I've been really interested in minimally invasive surgery since I was an early resident. We were exposed to laparoscopy and vaginal surgery, and actually some open surgery as well. And I just saw the advantages of it. So it's something that I've been passionate about ever since I started training. I had the opportunity in fellowship to get a lot of robotics training and more laparoscopic training. And it's just amazing how the field of minimally invasive surgery has really advanced. I continue to teach fellows here. We don't have residents because we don't have an obstetric program, but we work with, visiting residents and things like that. And it's just exciting to see them get out, branch out, and just advance minimally invasive surgery as well.
That's awesome. Well, can you explain to our audience what exactly single-port robotic sacral colpopexy is?
Sure. So the single-port robotic platform is a new platform. It is kind of the next generation that Intuitive has developed after the XI. I know the DV5 has just recently been launched as well, but this one is basically the whole robotic platform is centered through a 2.5 to 3 centimeter incision, what I place through the umbilicus. And all of the arms, so you're allowed 3 operating arms and an articulating camera that all go through that one incision. So, I like to bring this up because I always thought, we talk about keyhole surgery to our patients, and that's kind of how they know laparoscopy. But when I started doing laparoscopy, I was like, well, no one told me there were going to be 5 different keyholes, right? We have to make so many holes to do these surgeries, and single site surgery through small incisions is really the next advancement I see. So this platform is kind of the first platform that's really advanced and available for us to start operating on patients with.
So what's the advantage of using the single port robotic approach?
I think the obvious advantage is just one incision. I started this with sacral colpopexy mainly because I was doing supracervical hysterectomies. And after the I guess, death of the power morcellator, we had to make a little bit of a bigger incision. As urogynecologists, we're not typically taking out large fibroid uteri or anything like that. So we're just making an incision just a little bit bigger than we typically would to take that uterus out. And that's the same size incision that I'm using without having any other incisions in the belly. So it seems like the advantage is that I'm saving the patient 3 or 4 other laparoscopic trocar incisions while making the same umbilical incision. So hopefully less pain, quicker recovery, although I haven't yet proven that. So I have a little work to do.
So do these patients have a higher umbilical hernia rate?
Yeah, that's the biggest concern that I had going into it. Since I was already making that size of an incision with the supracervical hysterectomies, I think all of those patients would be at that same risk, right? It's not a bigger incision, but I was looking at that pretty carefully. And in my first 100 cases, I did find 2 patients that did have an umbilical hernia. One of them that did get operated on for a mesh surgery.
Oh, wow. How do you close that site then?
So right now I'm closing with a barbed suture, the barbed suture that's intended for fascial closure. I know there's a lot of different, when I went to Korea, they were closing with different types of suture, either single interrupted. Some people are using permanent sutures. I'm not sure that there's a lot of evidence saying one's better than the other. But I think if you look at the literature, a 2% umbilical hernia rate is pretty expected for laparoscopic surgery. So I don't think it's out of the norm for what we would expect.
I had heard the rate was much higher in talking to some of my general surgery colleagues and colleagues of mine that are minimally invasive surgeons who do a lot of hernia repair. The larger umbilical incisions, for things like gallbladders and stuff like that, they're quoting hernia rates as high as 25 to 30% over time from these bigger incisions. Have you read from the general surgery literature? Are you seeing that too, Johnny? I mean, 2% is very low, I would have thought.
Yeah, and I'm trying to keep close tabs on my patients, and trying to see, it's obviously possible that they have either hernias that they haven't told us about or hernias that are currently asymptomatic, just not diagnosed. But I haven't seen it that high, at least in the short term. I will say when I started thinking about this approach, our general surgeons, our hernia surgeons were a little worried that they were going to see more hernias. They haven't, we have a good relationship. They haven't really come to me and said, hey, this is a problem. This is something that we're seeing a lot of. So I'm not seeing it, increasing rates that high.
How long have you guys been doing it?
At this point, I've been operating with this platform for about 4 years. I've done about 120 cases. One of our urologists also uses it, and he does it for bladder cancer, so cystectomies, and he does the ileal conduits. So his incisions are much bigger. Kind of a small laparotomy size because he's pulling up the ileal conduit and things like that. I'm not sure. I haven't asked him about his hernia rate, but I think we have to be prepared for that as well.
Can you just walk us through? Well, first of all, I want to take a step back and say, what do you think the introduction of robotics, how did it change the landscape of sacral colpopexy surgeries?
Yeah. I think by the time I started training, robotics had already started being introduced to sacral colpopexy, and I think it took off pretty quickly as compared to straight stick laparoscopy, mainly because we do so much suturing, and the suturing was a little bit more advantageous with the robotic system. I'm not sure what the overall, what the breakdown is with straight stick versus robotics, but I think, there's a pretty significant proportion of urogynecologists that are using robotics for sacral colpopexy, I think mainly for the suturing. It's something that I trained both straight stick laparoscopy and robotics, and initially started doing them both ways, trying to get my fellows trained in both skill sets, and then advance it kind of over to single port robotics, mainly because I see the advantage of the system. I really do think that there may be some that still have yet to be explored, but it is something that I see to be beneficial.
Actually, Mark and I talked about this in a previous episode. Mark was all laparoscopy because he didn't have a robot, and then Mark kind of switched.
Well, I trained in Michigan where they had 7 robots in 2010, and I came to Kentucky where they had one for the entire institution. So I kind of got away from it for a while, but got back on the robot a couple years ago now, because most of my residents really, this is not about the residents of Kentucky, they're actually the best part of our program. But the surgical volume, when they get out, they want to be closing the cuff robotically. That's what their plan is. And so I felt like I probably ought to train them the way they're going to be operating. And so that was a big reason to get back on. But you talk about Colpopexy. For me, it's myomectomies. I mean, suturing myomectomies laparoscopically, like, it's cool to say you can do it. It's not cool to do it. It's not fun.
I had an interesting balance of my training. In residency. We really had no robotics. I did maybe 6 or 7 cases with one of the oncologists that was new there. And then in fellowship, I basically did a ton of robotics and vaginal surgery with Javier Magrina and Roseanne Co. And, they really showed me how to kind of be very efficient with robotic surgery and be a master robotic surgeon. And then I did my 3rd year of fellowship at Loyola, where they did mostly straight laparoscopic sacral colpopexy. So I always say, my path has not been the straightest path, but I feel like it's been one of the best paths that I could have had for surgery to get all that exposure.
Was Kim Kenton at Loyola when you were there?
She had moved to Northwestern. Yeah.
We had Maggie Mueller and Kim on, and they were doing a bunch of, single port. That was something that I hadn't really thought about that much. I actually went back to work and told my colleague, I'm like, we got that single port sitting over there. Do me a favor and get on it, would you?
Yeah, that is it's interesting. Can you just explain the single port, like, technical aspects of it? Because I know that it's like the what is that guy from the movies, Dr. Octopus? Dr. Octopus.
Doc Ock.
Like Doc Ock. That's right, Doc Ock. Like, because you have to be able to flex the camera and the instruments, and then actually, from what I heard from my colleague who is doing a ton of single port hysterectomies, was that, you can't really use a needle for the sacrum unless it's a Keith needle, but obviously you're able to do it.
Yeah. So it's all introduced as straight instruments through the trocar, but then once you get into the belly, the first thing you do is articulate all the instruments. So the camera has a way to articulate like a colonoscopy would. It basically goes up and down, almost looks, they call it cobra mode. So it looks like a cobra, a snake. So it does essentially have like a 30-degree down option. The arms also go out. So out and down. So there's the 3 o'clock, 6 o'clock, and 9 o'clock arms. So if you think of a clock face, and the right arm, the elbow goes out to the right, the left arm, elbow goes out to the left, and then the 6 o'clock arm, the elbow goes down. So you get more space, because if you've ever done single-site laparoscopy with straight instruments, you know that it's very difficult because you can't triangulate around it. But because the articulation happens, it allows all of your instruments to triangulate basically on your target and makes it a lot easier than trying to do single-site laparoscopy.
So how do you introduce the needle?
The incision is actually big enough to introduce all the needles. So we work through it. Intuitive has its own trocar system that goes through the umbilicus. And
is it like a gel port, or was it like?
Yeah, it essentially looks like a gel port. And when we started, they didn't actually have that. We started with a gel port. We actually just put the metal trocar through the gel port, and they developed this as we were moving forward. But yeah, you can introduce, I introduce all my needles through that same port that just go under or around the instruments to be able to place all the needles. So I really don't have any limitations there.
So you leave it in, you leave the whole single port robotic platform in the patient and just put the needle around it. So you've got, your incision's actually larger than the port.
It's true. It ends up being about 2.5 centimeters or so kind of a larger umbilical incision. But we were able to get all the needles through that. And I've never used a Keith needle for the sacrum, so I just use a normal Gore-Tex needle.
It would be very difficult. So you're using Gore-Tex, like the PS type needle?
Yeah, I think it's a THX 26 or 22 now. I don't know exactly. It's like the size of an SH needle. And then I use V-Lock actually to attach the mesh on the anterior and posterior walls. And that's also like an SH needle.
And then in terms of, what kind of qualifications or training would you say that surgeons need to have in order to perform single port surgery?
Yeah, I think training is really important, obviously, before we implement new technology with our patients. Safety is obviously the most important. At this point, it is still technically off-label for gynecology, so I should start by saying that. We had the opportunity of being one of the earlier institutions to get the platform, and that before our operating room was ready for it, it kind of sat in what we call the garage. So it sat in the back with dry instruments and things like that for mainly our urologists to get trained on it, because that's our urologists and the ENT surgeons were the ones that really wanted to bring it here. But it was sitting there and it allowed me the chance to kind of work on it in a dry lab setting before considering using it in a patient. Obviously you have to get comfortable with that. I think with the experience of multi-port robot and the intuitive platform already, the buttons to press and drive the car, as I like to call it, really are not different, right? It's just the way that you use the instrumentation is a little bit different, but the pressing the buttons and driving the joystick is really not that different from the other platform, the other intuitive multi-port.
So how is it different? And I won't try to answer it because I've not used it, but I've heard that it's different. What's different about how you use the instruments in a single port versus the traditional robotic platform?
Yeah, so the main difference, I think of the single port as having elbows as opposed to wrists. So there is articulation, but the articulation's a little higher on the instrument instead of lower, just right at the edge of the instrument, which you're used to with the multi-port. So it does make the articulation a little bit of a larger movement as opposed to a finer movement, but it doesn't seem to have limitations. You do have to learn how to kind of work on that, but it doesn't seem to be as limiting as some of the other platforms that I've tried, like single site laparoscopy or even the Intuitive's other single site robotics platform, which I thought was pretty limited as well.
Oh, using the crisscrossing.
Yeah, the one that crisscrosses and uses the XI or SI platform. I tried learning that en route to the SP, and I got officially trained in it. I started doing some cases, and I think there were so many limitations with that instrument. There really was no articulation there. There was limited instrumentation. You didn't have scissors that had electrosurgery on it. It just was too limited for me to feel like it was worthwhile.
So the elbows move and then the wrists rotate?
Exactly. And I think actually the biggest learning curve is learning how to articulate the camera. So you want to learn to articulate the camera so it's 30 down or 30 up, but you can also move it to the left and to the right, just like you would looking to one side wall or another. So all of that articulation takes a little bit more nuance and learning how to manipulate that. And I think that's one of the greatest advantages of this system. If you're working on the sidewall and you don't have a good view, you can actually turn your camera to the right or to the left, as opposed to just kind of looking at the side of your screen.
How long does this take compared to just doing a regular robotic sacral colpopexy versus a conventional laparoscopic sacral colpopexy versus a single port? What's the OR time look like?
Yeah, that's a great question. My first 20 cases I took, and this was my version of a learning curve study. So I took my first 16 cases, I think it was a single port versus the last 18 XI and the last 18 laparoscopic straight stick. And I compared those in terms of OR time, complications, hospital stay, and the OR time actually was no different. So from start to finish with supracervical hyst, sacral colpopexy, posterior repair typically in a sling, all of those cases took me on average about 3 hours, and there was no statistical difference in that. It's a small cohort, but we showed that there was no difference. And I think that shows that the learning curve for this in someone that's comfortable with robotics platform already is pretty quick, as long as you know how to use that platform.
Those are amazing times. I know you guys do a lot of robotics, and your team must be really, really good.
Yeah, I think we are efficient. And this is also in a teaching institution. So I know I don't have residents, but I do have fellows and, the typical academic institution where we have our fellows doing what is expected of them as well.
Do you think that in order for people to be able to do this surgery, you have to have the SP platform, or can you do it with an XI or SI, or not really?
No, for this platform, it's a different platform. So there is the single site platform for XI and SI. I've never done a sacral colpopexy on that. I think that would be just really difficult with the limited articulation that they have. There are reports of it. I think there are some people that really have advanced that field as well. But to my understanding, I don't know that Intuitive is really advancing that platform further, especially with the launch of this one.
It sounds like from your institution, it's gynecology, urology, NT. But do you know from your work in this space, are there other specialties that are really adopting the single port platform as well?
Yeah, I think if you look outside of our country, it's really exciting. So it was approved for gynecology in 2019 in South Korea, and I think more recently in Japan. But if you look at some of the literature looking at this platform, there's amazing things being done, including in plastic surgery. So they're doing, like, there's been some case reports of different types of plastics reconstructions, like flaps that are being done in Korea. And, actually in Korea, more gynecology is getting much more use than any other field, it seems like right now, because there's a huge push for single site surgery in general in Korea. And that's where I actually got a lot of my motivation to kind of advance that field as well. But I think there's a lot of potential use. I know our transplant team is starting to be interested in it as well. Our plastics team, I've actually been working with our plastic surgery team to do lymph node transfers for lymphedema surgery through the single port platform as well. I do partial omentectomies for them, and then they do an omental lymph node transfer to like the axilla or the groin for patients that have lower extremity or upper extremity lymphedema. So we're working on publishing our outcomes from that standpoint as well for single port versus laparotomy.
That is so cool. I know you do a lot of speaking work and speaker gigs in South Korea, but it sounds like they've really taken off with this particular technology. What do you think it is about Japan and South Korea that made them really adopt it? Is it like a push from the patients for cosmesis?
That's what it sounds like. It seems like they are really interested in how many incisions you're going to make, and that seems to be a big motivator. I haven't talked to the patient myself, but I think that seems to be what the case is. When I had a chance to go and observe some single port cases, and I just spent about 2 days in the operating room at Yonsei University at Severance Hospital, and it was amazing. I went to go see the single port robot cases, but I also watched some other single site laparoscopy cases. I think there was like one patient in like the 30 cases that I saw operated on in those 2 days that had more than one incision placed in their abdomen. It was amazing. I mean, they were doing radical hysterectomies, stage 4 endometriosis, fibroid uteri, endometrial cancer, all pretty much through one incision.
Wow, that's crazy.
Was it primarily robotic or primarily straight stick single site?
No, it's primarily straight stick single site laparoscopy still. Robotics is taking off. It looks like they've done, if I looked at the numbers recently, I think they have done as many cases in Korea as they have in America, but most of them are GYN, and it's like 4,000 or 5,000 cases with a single port robot. But most of the cases still are single site laparoscopy. It seems like there's a lot of interest in vNOTES as well, because now there's no incision, so that's even better.
I remember talking to somebody who used to be one of the speakers for the single site and saw him at AHL one night. I was like, "Do you do that?" He's like, "No, I hate it." Like it's not an easy thing to do. It is a completely different learning curve. It is a completely different almost surgery and approach. And I guess if you, like anything else, you do it a lot, you get good, but the learning curve is steep. And I see why it didn't catch on here, at least.
Yeah, I mean, I would say that I don't really ever get asked how many incisions it's going to take. Like, never. I can't think of it at one time.
I think that's true, but I think if we offered and we said, how many incisions would you want? I think that would be different, right? So when I talk to patients about it, I say, hey, I can do this through one incision or 5 incisions. You take your pick, because I'm very transparent about the fact that this is still off label. I've had 1 or 2 patients say, no, I want the other one, the older one.
For myomectomies, it's different because they're going to get a second incision later when they have a cesarean section. But if I say I can do all the entire surgery through a 4 centimeter mini lap, or we can do a robotic and then do a mini lap to get the fibroids out, and then you go back and get a C-section. They're like, we'll just do it through the one mini lap. And it's a bigger incision, but if that's a different surgery where you're going back again, ideally for a C-section. So this is different. I'm with Amy. I think it is definitely a shift in mindset, a shift in counseling, a shift in how we discuss it, because we just don't we don't really offer it because I don't do it, right?
Yeah, this just brings to mind I haven't been to Korea in a long time, but I've heard plastic surgery is really big and people are very interested in the cosmesis. That's why I asked this question, because if it's patient driven like that, I mean, Korea has a private and then the public. Everybody trades in the public system in the universities, but then everybody has there's also these private hospitals. And in your experience, was it like both the private and the public hospitals that were driving this, or was it more on one side or the other?
I'm not as familiar with the private system there. It seems like there are a lot of like private hospitals and clinics that do operations. I got a chance to visit one, and they interestingly did have a Korean version of a robot there that was like multi-port. But most of the people that I've been talking to have been academic institutions.
Interesting.
Can I talk to you about getting access to the patient's abdomen? So many of my patients have had prior surgery. So I'm going Barrett's needle left upper quadrant, OptiView left upper quadrant. As you're doing a bigger incision, are you just always going primarily through the umbilicus? And then talk about your incision.
Yeah, so I go transumbilical, just basically a vertical transumbilical incision. And we typically, I've always done a Hassan since fellowship training. Basically, I haven't used a Verres needle in quite a long time. But with the Hassan technique, it is, even though it's an open technique and it's supposed to be direct visualization, with a very small incision, you're limited to what you can see. So the nice thing is I get a better view, right? So I get a better view of the fascia. I can open that up. And once I get in and get entry, then I can extend that with what I truly think is direct visualization. So I think case selection is really important, especially early on with a new platform. So you don't want to pick patients like your typical patient probably, but you want to pick patients that maybe have a virgin abdomen or less surgery, where you're not expecting a lot of transumbilical adhesions. But I've gotten in those cases, and that was something that I really thought about when I started, because you can only fit one robot in a room. So when the SP was in the room, I couldn't convert to an XI case if I had to. So I had to think, if I have to convert, I'm converting to either laparoscopy or laparotomy. So if I had a lot of adhesions, then I had to either decide, am I going to do this with single-site laparoscopy or multi-port laparoscopy? And so I had to have some at least baseline skill set to be able to do single-site laparoscopic adhesiolysis. And I've had a few cases like that where I've taken down some momentum and things like that. So it does take that skill set. It's just like any other, like even with robotic surgery, you have to be a good laparoscopic surgeon to get in and dock the robot, right? So you still have to have those skill set to be able to take down those adhesions.
No, that's a really good point. Those cases where we get in, it's just kind of, you have to make room for the robot. They had an appy on the right side. You got to clean some stuff up over there for your right-sided port, or you have to use your laparoscopic skills first to allow yourself to dock the robot at times.
Are the instruments like 2 millimeters though? Like how long does it take to cut these adhesions? Like you're chomping away with like these little like microscopic bites.
They're smaller. They're not that much smaller. They're 6 millimeters each. So they don't feel like micro laparoscopy tools. They actually, I had to go back and ask the size because it doesn't seem that different than
regular scissors.
Yeah, it is. They are not as strong. So the grip isn't as strong. I think it's like 30% less strength in terms of the grip, but it's the size of the instruments don't seem that much smaller.
And that's what I think either Maggie or Kim were saying, though, for like the cases where we'll do like a 2 kilo uterus, based on the strength of the instruments, based on the articulation differences, based on the size of the vessel sealing. There are certain cases that are good for single port and some that may be less optimal. What's your thought on that? Because that was their experience, but they're not doing those bigger cases. Are you doing kilo uteruses with this thing too?
Yeah, I heard that a lot when I started, and people were like, well, you're not going to be able to do tough cases with this, right? And so I thought, okay, well, I'll just do what I do, which is mostly, hysterectomy, sacral colpopexy. And then I started to push my boundaries once I felt more comfortable. So at this point, we have a series, it's only about 8 or 9 cases of large uteri. So ranging from like 600 to, I think my largest was 1,100 gram uteri. And we were able to do this safely. So patients did not have any blood transfusions or, I think one of those patients was one of the hernia patients that needed that surgery. So it was a larger incision I think I had to make for the morcellation. But you just work in you work in different spaces. So the working space is a lot smaller. So first I start on the left. I have to work my way over to the right, whereas the XI just allows you to kind of have access to the whole field. But you definitely want to work slowly. You don't want to get into bleeding when, there's large vessels and things like that, especially if you want, but I haven't, with those cases, I didn't add another port. I didn't add another laparoscopic port. I was able to more slate through the abdomen, get those cases done safely. So I think once you're past the learning curve, I'm not sure that there's really a lot of limitations.
As you're able to put sutures through and around a single port, could you slip in a straight stick smart vessel sealing device and, just to get your big vessels? Is there a way to bring that in?
I think that would be a lot harder. So the assistant is actually very difficult. So because although you can pass things, right? I pass my suture, I pass my mesh. Getting your assistant to work around that narrow area and move around, they have very limited access. So
for like suction, probably, right?
Exactly. So I actually had to get creative with that. I didn't come up with this myself, but there were people using like a pediatric OG tube. At this point, I'm actually using a red rubber catheter. So I just use a red rubber catheter, cut the tip off, put a suture around it, and then attach it to my suction device. So I can grab that suture and just move it wherever I need to. And my bedside assistant is basically just pressing the buttons for me. So you do have to kind of come up with some creative ways to work around the limitations of the system. And I think there's a company now that's developed a flexible suction irrigation device for this.
Wow, that's pretty interesting. Well, we talked about the hernia risk. Are there any other potential risk or complication associated with this approach?
Whenever you take a new platform, you have to make sure that it works well. I mean, if you think about this is already approved for transoral surgery and intra-abdominal surgery. So for urology, it's approved for prostatectomy and nephrectomy. So I don't think that there's something unique about gynecology that makes it different. It's also pelvic surgery, intra-abdominal surgery. So we know these instruments work well. They were already cleared by the FDA to be safely used for operation. I think there's some nuances. We do different types of suturing. I know the DV5 with that new haptic needle driver has some warning with the vaginal cuff, right? So maybe there's some nuances there that you might pick up with larger studies. But I haven't come across anything where I would say, hey, this is a major complication that gynecologists should be aware of.
And then have you noticed any difference in the success rate compared to traditional methods?
I haven't. That's something I want to make sure that I'm not. Right now, I've done a lot of like short-term studies, and we're trying to get another cohort comparing XI and SP out that we're presenting, hopefully coming up soon. But we don't have long-term studies in terms of anatomic or composite outcomes. I try to keep an eye on that. I have one patient that did have kind of an anterior prolapse that I took back, but no apical failures that I know of myself. But I wonder, well, if the suturing going to be different? Is the strength of the needle driver going to be, if the strength of the needle driver is a little different, is the suturing not going to hold up? So those are things that I'm watching carefully as well.
And then how about the recovery process or post-operative period? Does that look any different?
Yeah, one thing that we're trying to publish right now off of the cohort study is that our SP cases seem to go home a little bit faster than our XI cases, but that could be a difference in terms of how our urology FPMRS surgeons are sending patients home compared to me, because they're the other people doing the sacral colpopexies at my institution. Long term, I haven't looked at like narcotics use and things like that I need to probably look into. But when I hear from my patients, a lot of them are actually saying that they had very minimal narcotics use. So I think
going home the same
great to
day
hear as well. Most of my patients are going home same day. Yeah,
that's awesome. Have you done a cost analysis? Like how does that compare for the single port versus traditional methods?
Yeah, I haven't done an official one. I did one early on when we started, and I was using like the gel port device and some other things like that. The drapes seem to be a little bit more expensive. When I was using XI, I was using 3 arms instead of 4 arms. So compared to a 3-arm technique, SP does seem to be more expensive. I think we'll have to look at how it compares to like 4 arms and, just all the instrumentation used and things like that as well. So I haven't done a formal one, but I think cost may be a concern. I think with any technology, any new technology, it doesn't seem to be getting cheaper, unfortunately.
Yeah, how much are these platforms costing? I don't even know.
Ooh, I couldn't tell you. I think they're upwards of $2 million. Like the XI, is it 3 now?
If you get the console, the teaching console, I think altogether it's like 2.3 without, so I'm closer to 3 with a teaching console, I believe.
Yeah, and we do have the teaching console for the single port as well.
I know one of the things people had, complained about the Da Vinci robot platform is there's no haptic feedback, but I thought that lended itself very well when it came to sim, like digital sim, right? As opposed to like dry lab sim. You're actually like, it doesn't matter. You don't have to, like if you're doing laparoscopic and it's a simulator, it's hard to kind of feel things, whereas we don't feel it anyway. So I thought that was a benefit of it. Is there a sim platform like a backpack you can get to train on single port as well, like there is on the traditional robot?
Yeah, what I understand is that it's really software. So I think if you have the backpack, you can upload some single port exercises. I haven't tried it yet. I think we're trying to get those uploaded to our system so our fellows can practice on it. But there are a few different buttons that are not on the XI, right? The camera control button. There's some mostly camera control buttons that are.
Is it just a picture
different.
of a cobra? Is that the?
There's actually on the surgeon platform, there is actually, it says Cobra pose, but it doesn't look like a cobra. That would be great. But there are some things that are a little bit nuanced there that I don't know how. We have an XI surgeon console with the backpack in our sim lab. And so I think there are some buttons that are different. So we'll have to try it out and see what the limitations are there.
Wow. That's super interesting. I feel like the sim on that must be totally different, because it's a different process, with the camera in addition to the instruments.
Yeah, I think the biggest difference is the working space. With the XI, you're used to working as wide. You don't really have to have your fourth arm in view all the time. I mean, they tell you should, right? And from a safety perspective, you should. That's how we teach our residents and fellows. But with SP, you really can't have an arm outside of view because it'll limit everything else because it's all coming through that 2.5 centimeter trocar. So you're really working in kind of a space I describe like a softball, where you're in that sphere area, and it's a lot smaller working space than you're used to with the XI. So when I go back on the XI after using the SP, I feel like I'm so free. Like I feel like my arms are like so loose, right?
Oh, you mentioned that it's not FDA approved for GYN surgery here. Do you know why? I mean, I'm sure it's a matter of time, but like what it is about the FDA approval process, or I'm sure it's 510K. I'm sure it's just it's not approval, but what's the term they use?
Clearance.
Clearance, right?
Yeah.
For gynecologic surgery, it's still abdominal surgery. Like, what's the process for that?
Yeah, I think there's going to be more clinical trials that are necessary. And right now, I had just heard that cardiothoracic got approved for use of the SP. And I know in Rochester, I think they're doing some colorectal studies as well. But to my knowledge, there's not any ongoing FDA trials that Intuitive is sponsored at this point. So we're working on getting that started. We want to try to do a 3-site enterprise-wide SP prospective study to try to help that along. I've done my best to try to publish as much as I can, and I know Kim Kenton's group has also been publishing as well. So at this point, that's all we can do. I know, unfortunately, a lot of the studies that are coming out of Korea, I'm not sure that our FDA is necessarily going to look at those, although they're valid studies, right?
Are you the only ones doing it, Chicago, and you guys the only sites that that are doing significant volume in this SP-GYN stuff, or are there a number of sites around the country?
I think it's growing. So I think there are a number of sites that are really growing. Xiaoming Guan at Baylor, you would probably know him. So I've been working with him because he's been doing single-site robotics for a long time, and also robotic vNOTES for a long time. So if a little plug for our surgical tutorial at AAGL, he'll be talking about single-port robotics as a route for SP, or as a route for vNOTES surgery as well. And he started publishing in that as well. Yeah,
we'll have to get him on. We were fellows at the same time, and his approach to surgical innovation, his drive is incredible. He's such a nice guy, first of all, starting with just like as a person. He's just such a nice dude. But we were, training at the same time to see how quickly he advanced and how he pushed himself, and how and not in an unsafe way, but just such an innovator all the way. And so that was actually my next question was, umbilical, is that the only port of entry for the SP platform when it comes to gynecologic surgery?
Yeah, so Xiaoming could speak to you more about that, but he'll talk about his vNOTES approach, and I think he's done several, and he's started publishing them as well for vNOTES SP as he's published for XI as well. I think in Korea and in Japan, they're starting to look at vNOTES as an option as well, but most of it has been transumbilical. So I think the majority of the research out there right now is transumbilical. For sacral colpopexy specifically, I calculated a little bit, and it looked like about 300 patients have been evaluated for transumbilical sacral colpopexy with SP, and there's not that much about vNOTES. But I think it's, with the articulation and the camera, especially to be able to look on the sidewalls, I think it really does have some promise there.
I remember I moderated a surgery at AGL from a surgeon in China. I don't remember her name, but she's an oncologist, but does pelvic floor reconstruction too. She blazed right through this hot mess, the chat was blowing up is that appendicitis? But anyway, it is doing all that dissection and avoiding the ureter from the vaginal side retroperitoneally is rough. I am curious to see his videos.
Well, we saw Jan. We had Jan on the show and talking about vNOTES, and it's one of our more popular episodes. But the way I did the course for vNOTES, I've not done a vNOTES case. It just, for what I do, is just not something I was interested in. But he would say it's actually easier. You can see it early on. You can identify it, and if you can identify it, you can avoid it. One of the challenges with vNOTES is similar to traditional single port laparoscopy, right? It's the articulation. You sort of have to move this way to go that way. SP actually sounds, I think it would honestly be a really nice way to approach a vNOTES case because it is limited in space. I mean, you'd have to think about how to set the port up. I'm actually very curious to see how Xiaoming is doing it. I think it actually makes sense just from a first pass for me. Oh yeah, absolutely. That's one of the things that I found quite challenging in the vNOTES course.
Yeah, I actually started vNOTES this year. When vNOTES started getting popular was when we got the SP robot around 2020. Maybe it was a little before that, but that's when it was am I going to do vNOTES? Am I going to do single port? How much can I really change in my surgical practice all at once? And I really decided to take on the single port. And Amy, you and I both do a lot of vaginal surgery. It's something that I was kind of well, it's vaginal surgery. We can do vaginal surgery. I don't need a laparoscope to do that. And I was kind of a naysayer for a really long time. And then I picked it up this year. And just being able to see exactly where the ureter is, see the nexa, all of those types of things with the laparoscopic magnification is really nice. So I do think I'm interested to see where it goes. I have not done a single port vNOTES case yet, but I think that's going to be something that's up and coming for me as well.
That's something that I know Andy Sokol is hot on it. He's always talking about that. It's the next wave of the future.
What's that single port robotic vNOTES?
vNOTES, yeah. Single port. It's a single port vNOTES sacral colpopexy. I will say that I trained in vNOTES. I can see the value of it. I think the peritoneum shears off really easily when you're trying to put the ring in. And by the time I put that ring in, I could be done with the case. Literally. I mean, I don't want to brag, but I'm a really good vaginal surgeon. So the fellows are not hot on it at all, because we do so many vaginal cases. And they're we could be done by now.
Yeah, it's true. I mean, from a hysterectomy perspective, especially with these small uteri, I think there's really not much utility for it. But, I will say placing the uterosacral sutures, when you can see where the ureter is moving while you're placing that suture, it provides a lot more comfort for trainees. And that is something that I've noticed. And, my trainees are, they're mixed fellows and they're very comfortable with laparoscopy. So they seem to really like that. And it's when I tell them, okay, we're going to place the uterosacral stitch vaginally, they're freaking out, right? I'm going to get the ureter. But with laparoscopic, you can totally see where it is, which I think is nice.
Are you the only one where you are doing single port?
Single port in my department, yeah. Paul Magdubai started this with me, and Firefly wasn't available for the endometrial cancers at the time, so he went back to XI. but now it is available. But no, I haven't had as much interest. Well, Jamal Murad actually is with us now. He's new to Mayo, Arizona, and I've done a few cases with him, and he's really liking that as well. He does a lot more fibroids and endometriosis, so I think we'll be able to publish more on that.
I think we've got him scheduled for an episode coming up.
Yeah, that was such a huge recruit for you guys. Jamal's a gem. Well, look, can you just tell me how have patients reacted to this, to the procedure? What are they saying? You walked us a little bit through the counseling. You said you were transparent, and how have they felt about the whole process?
Yeah, I think, now my robotics practice has really taken over by single port. I actually don't do XI cases unless it's something where I have an oncologist working with me and they prefer that, or a colorectal surgeon, and no one else is doing single port. So when I have a combo case, I'll do it with XI, or if the patient's just not comfortable. But at this point, all my robotics block time is on the single port. And the patients, when I talk to them about it, and I tell them, now I have published data of my own outcomes, and I can tell them what my outcomes have been, they seem very comfortable with it. There are some patients that have still said, no, I don't like anything experimental. I'd rather go with what is known, and that's totally fine. I'm definitely not pushing them. I just find a different spot for them, and use the XI or do straight sig laparoscopy. But it's been great. We actually did a small study looking at patient satisfaction with cosmesis with a validated questionnaire looking at scar, and it was 100% of the patients were satisfied with their scar afterwards, and better scores than the XI overall. So it's nice to see that. And subjectively, when I see patients back, they're super happy, right? They're like, you can't even see the incision,
Are you doing the omega incision, or are you doing the straight up and down?
Just straight through the umbilicus.
You must be doing a good job, because I've seen some of these belly buttons and they look messed up.
How do you close the belly button at the base of the umbilicus? What's your technique? Is it's just a little thin,
You mean for the skin, I assume, right?
Well, yeah, I mean, all of it, right? So because it's the fascia and the skin separates above and below the umbilicus, right at the umbilicus, it's all together, right? So tell us how you're closing if you're going straight through it.
Yeah, so I was doing a subcuticular, but if the skin really pulls off of the fascia, like a lot of times it does, I'll place one stitch, taking a subcuticular stitch, like a deep dermal stitch, and then just grab that fascia so it buries down. But we were having a lot of umbilical concerns, not in my patients, but in general with all of our surgical patients. And I was talking to one of our plastic surgeons that I work with a lot, and she's like, why don't you just close with interrupted sutures? So now I use a 4-0 Vicryl Rapide, and I just put interrupted sutures through. So those Rapide sutures dissolve much faster, and that interrupted suture allows me to just bury that bottom knot and grab a little piece of the fascia to just kind of bury that middle part. Yeah, I tell patients I'm gonna do everything I can not to give them an outie if they have an innie.
Yeah. No, I know. I can see that. You don't want an outie when you've had an innie.
And I'm sure a couple of my patients have not been happy with their scar, but like I said, I don't think that umbilical scar would be any different than what they would have had with any other surgery that I would have given them. So it's maybe slightly a little bit bigger, but not much.
And so even for your SI cases, you're going through the base of the umbilicus.
Yeah, that's how we trained here, and it was just a straight transumbilical incision.
What about you, Amy? For umbilical incisions, where do you make your incisions?
Yeah, I just go straight down to the lower aspect of the umbilical incision. But I trained here in 2006 to 2009 at Cleveland Clinic, and Amanda Fader and Pedro. Oh my God, I'm blanking on Pedro's last name. He's at AAGL all the time. He's in Puerto Rico now. Pedro and Chad Michener were all doing single port for endometrial cancer and HISTs. And then Kevin Stepp was doing a ton of single port too. And Kevin had all those courses. And then he was touting the omega incision. I remember that.
Yeah, I think it was 2009 that I actually went to his course. So Angela Chaudhary and Angela was my staff at Utah. And she and I went and took his course for single site laparoscopy. I remember that omega incision and all the kind of holding the instruments gangsta, like he talks about, and things like that, and how to do that single site laparoscopy. And that was kind of my first introduction to single site laparoscopy, but it really didn't progress from there because, like you said, Mark, the learning curve is so difficult.
Yeah, Pedro Escobar, that's his last name. But yeah, it was huge. But then it seemed like the enthusiasm kind of tapered out because the technology wasn't there yet. And it was just so much work and so much more time to do it that people were like, I can't be spending all day on this.
Well, you had to get different instruments. You had to get different camera. I mean, like, the camera angle, not the actual scope angle, but like, the angled camera to get it out of the way. There's all these things that seemed like you had to kind of put this whole kit together, and you ended up having this big incision where, again, going back to kind of our discussion here, like, where does it make sense? And so for me, I actually said this at the time, robotics is where this is going to be useful, right? You couldn't really see much of a benefit straight stick laparoscopy versus robotics. Like, it's, it's comfort, it's ergonomics, there's some value, but the clinical outcomes haven't really been there one versus the other. It's a surgeon approach, and there's that's totally fine. But single port, and I said it then, I said, this is too hard. The robot, if they really want to do something and separate themselves, single port is where that's going to happen. And when I first saw the first images of the SP, I was like, oh man, there it is. Like, it's just a matter of time, and it's going to get better. The instruments are going to get stronger, and they'll articulate. I'm sure they're working on other stuff, which I'm sure you can't talk about, but I think that's where the advances can be made, because it's just complicated to do. It's just, you're operating backwards a little bit to do it straight stick.
Right now, they don't have a vessel sealing device, and they don't have a suture cut needle driver. And so that, of all the things that I want, a suture cut needle driver is what drives me crazy, because we do so much suturing for sacral colpopexy. But
so they have a bipolar, just not a vessel sealer and cutter.
Right. They have bipolar fenestrated. They have Maryland bipolar, and then they also have a clip applier, which I use for some of my omentum cases. So they have most of the instruments. I think it'd be really nice to have a vessel sealer, and the suture cut seems like such a minor thing, but it's just when you have to cut a bunch of suture, it gets annoying.
Engineers are hearing this going, minor thing. Why does he come build one? Fitting it through a tiny little hole. Oh, come on, get with it, Intuitive. Get it figured out.
What do you think the future holds for, this kind of technology? I mean, are there other platforms coming out? Are like other indications, other innovations? You talked about some of your wish lists on instrumentation. What are your thoughts?
Yeah, I expect to see the other robotic platforms that are coming out, the competitors to Intuitive, to come out with single port devices. I think some of the prototypes have already suggested that that's going to be the case. I think it would be nice to get more advancement in terms of the instrumentation and also the FDA approvals, right? I really don't think that there's a reason why this should just be used in urology for prostates and men. We really should be able to offer this for women as well in gynecology. And I think that's something that I'd like to be a part of. And I think that's really exciting for me to be a part of. Vaginal surgery through robotics, I forget who it is, but they're always like, you're going to take a really cheap surgery and make it really expensive. And I don't...
That's Andy.
That's Andy Walter, right?
No, Andy Sokol. Andy says that all the time.
I think Walter says that too. And I think that's true, right? And I think you kind of have to understand what your limitations are. Like, do you need to do a robotic vag hyst for a 3-centimeter uterus? Or should this be reserved for large fibroid uteri and things like that? I think we need the studies to kind of look into that. But I see the future being single port. I see the future making we try to offer minimally invasive surgery to our patients, having minimal impact on their lives, and the less and less impact we can have, the better. And I think this is one way that we could do that.
That is so cool. Well, thanks for innovating in this space. I think people will be really excited to hear the kind of work that you're doing. They may even travel to Scottsdale, who knows, to get their surgery. And I think that's something that we are going to look at in our field and just be like, wow, thank you for paving the way,
Yeah, and I think the best we can do is really just publish our outcomes, right? Javier Magrina taught me that. He was one of the pioneers of robotic surgery and showing what can be done with robots and the outcomes and things like that. So I'm doing my best to try to publish as much as I can as well.
Awesome. Well, thanks for coming on the show.
Thanks so much. That was great.
Of course, thank you.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Urogynecology.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.